So it's a grade 3 burn, and fluorescent stain was positive. Interior chamber was shallow, hazy with fibrin reaction. This was the picture before treatment. So immediate management, we have done copious irrigation, as we all know, with ringer lactate 2 liters immediately upon arrival, and then I started the topical antibiotics, moxifloxacin first. अच्छा, यहाँ पे एक सरप्राइजिंग थिंग ये थी कि वी यूजुअली स्टार्ट विद अ ब्रॉड स्पेक्ट्रम एंटीबायोटिक, मोस्टली वी यूज moxifloxacin. So whenever after 48 hours the patient came, that as soon as I instilled that drop, मुझे ऐसे लगते हैं जैसे वही एसिड मेरी आंख में डल गया है, बिकॉज हाइड्रोक्लोरिक एसिड के साथ जैसे विगामॉक्स में भी लाइक अगर हम देखें तो उसमें भी इवन मॉक्सीगैन जितनी भी अच्छे ब्रांड्स हैं मैंने उसमें नोटिस किया कि देयर इज़ अ प्रिजर्वेटिव हाइड्रोक्लोरिक एसिड भी ना, तो HCl के साथ द पेशेंट वॉज नॉट हैप्पी, सो आई शिफ्टेड हिम टू क्लोराम्फेनिकोल एज सिंपल वन, बट ग्राम पॉजिटिव कवरेज उसकी गुड थी, सो ही रिस्पॉन्डेड वेरी वेल to chloramphenicol as compared to quinolones. So that's quite a learning point for me also, that moxifloxacin don't work in all the cases. So second, topical ascorbic acid drops. We all read in the books that ascorbic acid drops, these are not available in Pakistan. So I heard a speaker from India. दे सेड कि आपका भी कंट्री हमारी तरह बहुत एक पुअर कंट्री है, तो हमारे पास तो एस्कॉर्बिक एसिड के ना कोई ड्रॉप्स आते हैं ना किसी ब्रांड नेम से. सो यू जस्ट डिजॉल्व अ टैबलेट ऑफ सीकॉन इन डिस्टिल वाटर, लाइक प्रिजर्वेटिव वाली बॉटल ना, लाइक कोई टीयर्स वाली आर्टिफिशियल टीयर्स की बॉटल आप एम्प्टी कर लें, उसके अंदर डिस्टिल वाटर डालें 5 ml और एक टैबलेट उसमें मिक्स करके सीकॉन. दैट वॉज अमेजिंग. ग्रेड 3 बर्न्स में पेशेंट आया था तो आई वॉज लाइक के देयर इज़ नो होप कि इसका कुछ बनेगा भी सही. लार्ज एपिथेलियल डिफेक्ट था, रिस्पॉन्ड नहीं कर रहा था इनिशियली. फिर उसके बाद मैंने उसको एड ऑन किया ऑटोलोगस सीरम आफ्टर 5th डे ना, बिकॉज द सेम एपिथेलियल डिफेक्ट, कोई इम्प्रूवमेंट नहीं हो रही थी, तो मैंने उसको ऑटोलोगस सीरम पे डाला. उसका 5 cc बल्कि 10 cc ब्लड लेते हैं, तो उसमें से फिर सीरम आप एक्सट्रैक्ट करके दे देते हैं. और पेशेंट को ऑब्वियसली प्लम्बर है, पुअर सोशो इकोनॉमिक स्टेटस से है, तो उसको आपने गाइड भी कर देना है कि जी इसको इसकी रेफ्रिजरेशन प्रॉपर रख लें या ठंडे उसमें वाले पानी में रख लें या किसी तरह से भी ना. और आफ्टर एवरी 48 hours यू हैव टू कम बैक फॉर नेक्स्ट सीरम, या 72 hours तक भी चल सकता है. And patient was quite painful, so I have to add atropine also, topical and oral analgesics. So this is the whole scenario. Gradually the epithelial defect is healing, first picture, second, third and fourth. So it took about 4 to 6 weeks to heal. Sorry. Day 2 and day 5, I cut short this thing. The take-home message is the vision improved to 618 with mild central corneal scar, and later on, this was the picture at 3 months. I have taken this with my slit lamp, and the last picture on the right side shows there is a सिंबल एफ्रॉन फॉर्मेशन ऑल्सो. अब कॉर्निया बेशक अच्छे से क्लियर हो गया, लेकिन एक सेंट्रल स्कार है और साथ में सिंबल एफ्रॉन है. इसका रिहेबिलिटेशन प्लान हमारा यही है, हम सेकेंडरी ग्लोकोमा के लिए इसको देखें और सिंबल एफ्रेक्टमी प्लान करेंगे आफ्टर 6 to 12 months. Cornealistic burns, though less penetrating, can cause serious ocular mobility or morbidity. So this is Roper Hall classification, and that's all for it. Thank you so much.
Thank you.
Pointer, can you see this? It's not as actually visible as much, but so K1 is about 40, K2 is about 40 as well. This is about, the thinnest location is 546. Kmax is 41. Everything seems okay, right? And here, as such, there's no like alarming sign. It's plus 15 here at the thinnest location. When you go to the Bellin ambrosia, just this yellowish spot is present here, but when you see the TBI, it's 0.5. So this is a bit more than borderline. Despite the recommendations against refractive surgery, the operating surgeon decided to proceed with trans-PRK of the left eye. This is how I felt. It was like, come on. This was not a case of refractive surgery. So, first of all, if you were to proceed with refractive surgery of the left eye, why would you want to induce so much anisometropia? एक eye 6/6 हो जाएगी, एक eye 660 हो जाएगी. Why? दूसरा ये था कि true unilateral keratoconus doesn't exist. Form fruit keratoconus. Now, this is a condition in which an eye has a normal topography, normal slit lamp examination, and there is keratoconus in the fellow eye. So in this case, the right eye had keratoconus, left eye appeared completely normal on pentacam, but Corvus picked it up. Form fruit keratoconus can be picked up on Corvus, and that is why biomechanical index is so important, TBI is so important. So these are some of the values. It's difficult to remember them, but this is how it presents in form fruit keratoconus. If you want, you can take a picture of this. When we told the surgeon not to proceed with the surgery, he argued that the deformation amplitude of the patient's left eye was okay, stiffness parameter was okay, but that's the thing, you take into account different parameters, not just one. So you have to see what the overall picture is. In conclusion, you concentrate on the quality of life of the patient. You just don't go for refractive surgery. नहीं उसके लिए अच्छा होगा, you say कि नहीं है आपके लिए अच्छा. Even in the presence of normal topography, borderline TBI can indicate underlying susceptibility of ectasia. इस case में ectasia develop होगा later on. So Corvus ST is a diagnostic necessity. Now, since we have a minute, how do you think you would want to proceed in this case? What would you do?
इस केस में तो keratoconus है, एज अगर कम है मुझे मालूम नहीं क्या है, तो आप
22.
तो CXL करना चाहिए बोथ आईज के ऊपर. दूसरी आई के अंदर भी तो पोस्टीरियर ectasia borderline के अंदर
हाँ.
तो CXL होना चाहिए.
तो इसके अंदर 3 approaches थी.
नंबर 1 एक ये, और दूसरी ये हो सकती है जो राइट आई में जो केराटोकोनिक आई थी उसके अंदर जो स्ट्रेट अवे जो है वो CXL ही होगा. लेकिन जो दूसरी आई है उसके अंदर आपके पास ऑप्शन है, आप जो है उसके अंदर टी कैट कर सकते हैं. उसकी थिकनेस 450 माइक्रोन से ज्यादा थी, तो MS39 असिस्टेड उसके अंदर टी कैट प्रोसीजर आप कर सकते हैं ताकि उसकी कॉर्निया की जो भी कॉनिकल प्रोट्रूजन है उसको स्मूथ कर दें एग्जामिनर से. और उसके बाद बट दैट हैज टू बी टोपो गाइडेड, और इसके लिए आपको पैरामेस भी चाहिए और इसके लिए आपको सीरियस का इनपुट भी चाहिए ताकि ऑक्यूलर वेव फ्रंट गाइडेड ट्रीटमेंट हो जाए, ताकि उसकी जो रूट मीन स्क्वायर वैल्यू है हाई ऑर्डर विजन की उसको आप कम कर लें. मतलब विजुअल एक्टिविटी 66 का मतलब हरगिज़ ये नहीं है कि उसमें सब कुछ सही नजर आ रहा है, उसकी खामखा कुछ ना कुछ बूस्टिंग ऑफ इमेजेस होगा. तो वो MS39 असिस्टेड आप टोपो गाइडेड लेजर करके यानी कि एग्जामिनर प्लस CXL दूसरी आई के अंदर हो सकती है. राइट आई में सिंपल आप CXL ही करेंगे और कुछ नहीं कर सकते. CXL हो जाए बाद में फिर आप ICL टॉरिक लगा सकते हैं.
हाँ, ICL टॉरिक लगा सकते हैं, लेकिन उससे सो आई डिस्कस दिस एज वेल. ICL के अलावा TransPRK बिकॉज उसकी थिकनेस अच्छी है. इफ़ यू गो फॉर CXL, हाँ, एंड एवरीथिंग स्टेज स्टेबल, यू कैन प्रोसीड विद TransPRK. इसके 3 अप्रोचेस हैं. एक तो ये कि आप CXL करके बस ऑब्जर्व करते रहें इसको 3, 6, 12 मंथ्स. दूसरा अप्रोच ये है कि आप कुछ भी ना करें एंड जस्ट ऑब्जर्व. तीसरा अप्रोच ये था कि CXL प्लस TransPRK लेटर ऑन, बिकॉज हमारे पास रेजिड्यूल थिकनेस अच्छी है इसके अंदर, 300 से ऊपर होगी ये. सो थैंक यू वेरी मच.
Assalamualaikum. Thank you for giving me opportunity to talk about tiny samples, big impact, challenges in a microbial diagnosis of corneal scrapings. I'm Dr. Mona Malik, working as assistant professor pathology at King Edward Medical University. So the story begins around 12 years ago when I have observed that the corneal scrapings were neglected in microbiology lab. So I designed my MPhil thesis on infective keratitis. You know about that it is a common dreadful ocular infection of cornea characterized by epithelial scarring and stromal inflammation, and keratitis is responsible around 20 to 30% of all visual loss in developing countries. Pakistan and India is covering a large agricultural population, and numerous environmental factors are responsible for causing these corneal scarrings. So proper clinical management of infective keratitis required culture, which is the ideal diagnostic procedure, and direct imaging can also help for the prompt diagnosis for the clinician. We designed SOPs how to take the sample of corneal scarring, infective keratitis in theaters or in OPDs, and then also developed the SOPs how to tackle these precious samples in microbiology lab. Antibiotic, I have developed these SOPs in 3 tertiary care hospitals of Lahore. Lahore General Hospital, I worked there, CMH Lahore, and now working in King Edward on these precious samples. Antibiotics और antifungals should be hold for 24 hours. ये clinician बिल्कुल भी hold नहीं करते. Patient present करता है स्कारिंग के साथ और साथ ही ड्रॉप स्टार्ट हो जाते हैं, तो ये एक बहुत मैंडेटरी इंपॉर्टेंट पॉइंट है जो नेगलेक्ट हो जाता है. तो जो ड्रॉप्स हैं वो होल्ड हों 24 आवर्स प्रायर, और रूटीन में जो है आप उसको क्लीन कर सकते हैं अल्कोहल के साथ. वैसे इन्फेक्टिव होता है तो बेसिकली क्लीनिंग इज़ नॉट मैंडेटरी. आप जस्ट अल्केन और उसको लोकल एनेस्थीसिया दे के जो है वो स्क्रैपिंग ले सकते हैं. मोस्ट इम्पॉर्टेंट थिंग कि हम डेड डेब्री को स्क्रैप करके भेज देते हैं जिसमें माइक्रो ऑर्गेनिज्म आइसोलेट नहीं होता. तो आपने नेक्रोटिक टिश्यू को रिमूव करना है और उसके बाद जो मार्जिन एंड बेस ऑफ अल्सर है वहाँ से स्क्रैपिंग जो है वो करके तो माइक्रो लैब में भेजा जा सकता है. सबसे ज़्यादा इम्पॉर्टेंट चीज़ ये कि रूटीन में देखा गया है कि स्लाइड्स के ऊपर जो है वो आप सैम्पल भेज रहे होते हैं. तो जो 3 सेटअप्स में मैंने काम किया है उसमें मैंने ये SOP डेवलप की थिएटर्स में या ऑफ्थल्मोलॉजी डिपार्टमेंट में जाके अवेयर किया और उनको कहा कि आप पेशेंट की प्रिस्क्रिप्शन पे हमें कल्चर प्लेट्स की रिक्वेस्ट भेज दें. हम आपको कल्चर प्लेट भेजेंगे और उनको ट्रेन किया कि हाउ टू इनोकुलेट ऑन दीज कल्चर प्लेट्स. तो ब्लड, मैकॉनकी, चॉकलेट एंड सेब्रॉड, दीज 4 प्लेट्स शुड बी मैंडेटरी फॉर इन्फेक्टिव केराटाइटिस. कि आपका बैक्टीरियल और फंगल दोनों कोजेज़ जो हैं वो उनमें प्रॉपरली आइसोलेट हों. फास्टीडियस ऑर्गेनिजम्स के लिए कल्चर जो है वो चॉकलेट एगर के ऊपर मैंडेटरी है. वो ब्लड पे जो है स्ट्रेप्नीमो या हेमोफिलस ग्रो नहीं कर रहा होता. और सेब्रॉड जो है वो भी वेरी इंपॉर्टेंट क्योंकि मेजॉरिटी मेरे भी जो ऑब्जर्व केसेस हैं उनमें फंगल कैरेटाइटिस बहुत इंपॉर्टेंट जो है वो कॉजेटिव एजेंट रहा है. स्लाइड प्रिपरेशन इज़ वेरी इंपॉर्टेंट. हम वेट माउंट KOH प्रिपरेशन आप पढ़ते हैं वो कर सकते हैं. ग्राम स्टेन, जिम्जा एंड किनियन स्टेनिंग डिपेंडिंग अपॉन दी टाइप ऑफ ऑर्गेनिज्म वो आप रिक्वेस्ट करेंगे एज अ ऑप्थल्मोलॉजिस्ट कि वी आर सस्पेक्टिंग ट्यूबरकुलस केसेस तो हम केनियन स्टेनिंग की तरफ जाएंगे. और वेट माउंट हम हर किसी का कर रहे होते हैं फॉर फंगल हाइफी. और ग्राम स्टेन जो है वो यूजुअली मोस्ट ऑफ द बैक्टीरिया जो पैथोजेनिक हैं फॉर कॉर्निया वो उनको कवर कर रहा होता है. स्टैट्स ऑक्यूपेशन में जो है वो मेजॉरिटी लाइफ स्टॉक और फार्मर्स ऑब्जर्व किए मैंने अपने केसेस में. अराउंड 100 केसेस मैं अब तक कैरेटाइटिस के देख चुकी हूँ. बैक्टीरियल में जो है वो 22%, 38% जो है वो फंगल आइसोलेट्स हुए. एंड मिक्स्ड ग्रोथ में बैक्टीरियल एंड बोथ फंगल भी हमने 6% केसेस हैं उनमें देखे. Organic and vegetative foreign body injury is most common. No trauma की हिस्ट्री भी दी गई लेकिन उसको भी हम कोरिलेट नहीं कर सके. बैक्टीरियल आइसोलेट में स्टेफिलोकोकस ऑरियस, स्टेफिलोकोकस एपिडर्मिडस, स्ट्रेप्टोनिमाई, क्लेप्सिएला, इकोलाई, एसिनेटोबैक्टर और एक केस हमने नोकार्डिया का देखा. फंगल आइसोलेट्स हमारे ज़्यादा थे और फंगल में हम लोगों को ये एक्सपर्टीज़ थी कि हमने जस्ट जीनस नहीं स्पीशीज़ भी जो हैं आइडेंटिफाई करके पेशेंट्स की बताई हैं कि एस्परजिलस की आगे स्पीशीज़ कौन सी हैं. स्पीशिएशन जो है इट्स वेरी इंपॉर्टेंट माइक्रोबायोलॉजी परस्पेक्टिव के कुछ ऑर्गेनिजम्स जो हैं वो इंट्रिंसिकली रेजिस्टेंट होते हैं. दे इनहेरिट जीन्स कि उसके ऊपर एंटीबायोटिक वो असर ही नहीं कर सकती. एग्जाम्पल एक छोटी सी देती हूँ. जो सूडोमोनास एरेजिनोसा इन्फेक्शंस हैं मोस्ट कॉमनली आइसोलेट होते हैं आई के इन्फेक्शंस में. और उसमें मैंने देखा कि डॉक्टर्स जो हैं वो सेफ्ट्राइक्सोन दे रहे होते हैं. सूडोमोनास इज इंट्रिंसिकली रेजिस्टेंट टू सेफ्ट्राइक्सोन. उस पर कभी भी सेफ्ट्राइक्सोन असर नहीं करेगी. तो सेम जो है वो डिफरेंट एंटी फंगल्स का भी इसी तरह का पैटर्न है. सो केसेस थोड़े से दिखा दूँ डायरेक्ट माइक्रोस्कोपी में. ये फंगल हाइफीज हम लोगों ने आइसोलेट किए हैं डिफरेंट डायरेक्ट स्टेनिंग में. नोकार्डिया का केस है, डिफरेंट कल्चर्स ऑन विच वी डिड स्पेसिएशन. अच्छा, एक चीज़ बस, आप लोगों को जब प्लेट भेजी जाती है तो उसको बहुत ज़्यादा देर तक आप ओपन रखते हैं, तो उससे हमें ये कंटामिनेशन मिलती है. तो जिस टाइम ऑफ इनॉकुलेशन है, आप सिर्फ लिड उसकी उसी टाइम ओपन करें तो वो इनॉकुलेशन जो है आपकी प्रॉपर होगी, वरना इस तरह एयर की जो कंटामिनेशन है वो हमारे पास आ जाएगी. सो टेक होम मैसेज, कॉर्नियल स्क्रैपिंग दो माइन्यूट carry immense diagnostic weight. The accuracy of microbial identification directly determines the patient outcome. Thank you so much.
My name is Hamza. I'm presenting comparative evaluation of treatment for VKC. Now, what's VKC? You all know. It's chronic allergic inflammatory eye disease, primarily affects children and adolescents. The pattern is seasonal or perennial. Prevalence, it's prevalent in tropical climates. 5% prevalence in some regions has been reported. There is a male preponderance, that is 70 to 75% affected are males. Symptoms may persist for several years. The clinical symptoms, severe itching, redness, tearing, photophobia, and the signs, most common signs are papillary and Horner Tontas dots. What's the pathophysiology? Immune mechanisms are involved. T helper 2 lymphocyte activation, mast cells and eosinophils are involved. Cytokines involved are interleukin 4, 5 and 13. Chronic inflammation leads to tissue remodeling. Main treatment categories are antihistamines, mast cell stabilizer, lubricants, corticosteroids and immunomodulators like tacrolimus. Objective of the study was to compare the clinical effectiveness and safety of tacrolimus 0.03% ointment with olopatadine 0.2% eye drops in patients with VKC. It was a cross-sectional study. 288 patients were enrolled, 144 in each group. Follow-ups were 8, 4, 8 and 12 weeks. Baseline characteristics, mean age was 12.6 years, 73.6% were males. Mean VKC duration was 3 years. Similar severity levels in both the groups. Symptom improvement, tacrolimus showed 75.3% reduction in itching, 75.6% in redness, and 66.7% in tearing. Compared to olopatadine, the scores were 58.3%, 61%, and 51.4% respectively. Now, clinical outcomes at weeks 12. Complete relief, tacrolimus 77.8% versus olopatadine 58.3%. There was faster improvement in the tacrolimus group, that was 14.2 weeks days in comparison to olopatadine, which was 21.6 days. Fewer patients showed no improvement in tacrolimus group. Adverse effect comparison. Tacrolimus more burning and discomfort, higher overall side effect rate, that is 63.9%, while in olopatadine, fewer reactions were noted, only in 20.8%. Patient satisfaction levels, 76.4% very satisfied with tacrolimus, 59.7% very satisfied with olopatadine. No dissatisfaction reported in either group. So key discussion points, tacrolimus was more effective but more irritating, greater symptom reduction, stronger patient satisfaction, and requires careful monitoring. Conclusion, tacrolimus provides superior symptom relief and faster recovery. However, due to higher side effects, monitoring is essential. Overall, tacrolimus is preferred where efficacy is priority. Thank you for listening. Next presenter is Ryan Sabi. Ryan Sabi मौजूद है? नहीं है. हाफिज अब्दुल रहमान मौजूद है?
अच्छा सर, आपसे रिलेटेड एक क्वेश्चन.
जी बिल्कुल.
मैं I have been using tacrolimus and have seen जिस तरह के परसेंटेजेस आपने दिए,
जी,
मतलब इतने क्या इससे ज़्यादा के रिजल्ट्स हैं.
ठीक.
बच्चे तो बिल्कुल नॉन रिस्पॉन्सिव हो जाते हैं और टॉपिकल स्टेरॉइड्स तो एक हद तक हम दे सकते हैं, एलोपेटाडीन के साथ भी नॉन रिस्पॉन्सिव हो जाते हैं, देन दे डू बेटर विद टेक्रोलिमस क्लिनिकली. बट इसमें एक पॉइंट था, समवेयर आई heard a talk you should stop the other things. So I usually in my practice I do both of these together. So is there any interaction you have noted in your practice, or we can give olopatadine and tacrolimus, क्योंकि जो tacrolimus के इस तरह के effects हैं, burning sensations, और वो चीज़ें भी olopatadine अच्छा cover up कर लेती है. So I have been using these two together in patients.
You can use it together, but actually हमने शुरू किस तरह किया कि वो पेशेंट जो resistant थे, who are not responding to olopatadine and even low potent steroids, तो उनको हमने टेक्रोलिमस पे डाला. स्टेरॉइड को तो आप बहुत अरसे तक नहीं दे सकते,
Obviously, short term
मतलब
use.
आप देंगे, तो उनमें पेशेंट ने बहुत अच्छा रिस्पॉन्ड किया. फिर उसके बाद
So again the question is same कि we can give both of them together. वो तो study थी ना.
आप दे सकते हैं, आप दे सकते हैं, लेकिन इवन आप अगर अलोन सिर्फ टेक्रोलिमस दे दें तो उसमें पेशेंट भी बहुत अच्छा रिस्पॉन्ड करते हैं. So we have the last presenter because
What parameters we have to monitor in this patient?
पेशेंट फॉलो अप जरूरी है ना, इसलिए कि इनमें इरिटेशन और डिस्कम्फर्ट इन कंपैरिजन टू ओलोपेटाडीन ज़्यादा है. तो अगर पेशेंट को इससे ये डिस्कम्फर्ट है तो ज़ाहिर है फिर आप स्विच ऑफ करेंगे. लेकिन अगर if the patient is doing well, then you can continue with this. Initially we start with BD dose, but later on you can switch to OD dose for a long term. अच्छा, so we have our last presenter, Umar Ilyas. Devices for anterior क्या यार? Comparative evaluation of pentacam and क्या? Scansis Schemflug. Okay.
Bismillahirrahmanirrahim. I'm Dr. Umar Ilyas and I'm currently working as assistant professor at Park International Medical College, Peshawar. So there are two Schreiber devices, one the Pentacam and the other is ScanSys. So we'll be doing the comparative analysis between both the devices. So to begin with, there are no financial interests, neither with the manufacturers nor with the national distributors across our country. So these are the two Schreiber devices, one well-known market leader for almost 3 decades now, and then there is a new entrant which is the ScanSys from Mediworks and is made in China, right? The background is that there is a huge population now entering into the refractive error. So obviously there will be more entrants now, new entrants into the market. So we have to compare and to check for the inter-device agreement across various parameters. So 32 eyes were examined both on Pentacam and then on ScanSys. All 3 categories were included: the normal, the post laser vision correction, and also the ectatic corneas. So 6 months duration. ScanSys was performed at one hospital, and at other hospital, Amanat, we did the Pentacam HR. A strict protocol was used to make sure that there should be a single operator, one with each Scheinflug device. That is, one with the Pentacam and other with the ScanSys. And the temporal protocol was also used. We make sure that both the scans of a single eye should be taken within 1 week, right? But remember, more than 90% of the scans, they were taken in a single day. Of course, the inclusion criteria included the clear optics and the quality specification to be within the normal range. And the exclusion criteria, quite obvious, is that we excluded the corneas with scarring and active diseases. Now, 2 types of parameters were analyzed. One, the numerical parameters, right? Like the K1, the K2, that have got the numerical values. And then there is another parameter that actually classifies into normal, borderline, or ectatic cornea. So 2 types of parameters. The numerical parameters are on one side, and then there is diagnostic parameter. So have a look at this. This is well known to all of you. This is the 4-map refractive display from the Pentacam. Very similarly, we have got the 4-map refractive display from the ScanSys, which is another Scheinflug device. Now, this is the enhanced ectasia display. Similar parameters are utilized by the ScanSys as well. Only the display in the printout is different. You can see the bars for the front elevation and for the back elevation. They call it KCI, keratoconic index front, and the keratoconic index back. The output is different, I mean, in the form of the horizontal bars, and only one of them, depending upon the operator whether he selects front or back, is displayed in a similar manner to pentacam, right? Then comes the bad D display. Now you might say that this is the copy. Why this is being copied, this enhanced ectasia display developed by Professor Bellens, why it is being copied by these scanses? No. This is not the proprietary for the pentacam. You would find it in multiple other devices, like for example, the polished OCT, the night, we call it optopole OCT. Similar criteria is used. The other, Visionix, US made Optopo, we call it OptoView OCT. You find this similar ectasia, enhanced ectasia display in that as well. Then there's another one, the UK made the Harkstride. They also use a similar parameters when it is about the enhanced ectasia display. The proprietary is this bad D, right? Bad D. This is actually a multivariate analysis that makes anterior elevation, posterior elevation, the pachymetry progression. It's a multivariate analysis, and this is actually the proprietary. It classifies into normal, borderline, or ectatic. We have got a similar parameter over here, which is written KCP, which is the keratoconus probability. So, two types of parameters. One, the numerical parameters, that they are simple, and then the other parameter, which is actually the class identifier, the stratified risk, that is the normal, the borderline, and the keratoconic. So, we have got two types of parameters now. This is the bad D, right? With the normal and the borderline and the other values. And on the scanses, we have got the keratoconus probability display that is expressed slightly differently in the form of percentages. So that will be, we will analyze it on the basis of the classification, normal, borderline, and keratoconus. So remember, I need your attention over here. There are two types of parameters. So there are statistic analysis is in front of you. This is known as the Pearson correlation. What does that mean? When we analyze the data, we'll check for the linear correlation. For example, K1 on one device is going up, so it will tell you, yes, the K1 on other devices also going up. So this is the Pearson correlation, the statistical variable. But for the inter-device agreement, we need to have a bland Altman graph, which is the level of agreement should be lying within the 95% of the level of agreement. Then this is actually considered as the gold standard when we are having a comparison, as we are having this comparison of numerical values. The third one is utilized for the classification, right? And I'll be explaining it in coming slides. Have a look at this now. SIMK1, the linear correlation, the Pearson correlation is approaching almost 1. Excellent correlation. Have a look at this K2. Again, this value is very close to 1. 1 means 100%. So it is again very close following, but this is just telling you the linear correlation. Remember. The same goes with the pachymetry.
It's okay. Continue.
Pachymetry. The only difference lies 7 microns, right? Now, this is the bland Altman summary, and this is the gold standard. When we say that there is 100% or reasonable or clinically relevant inter-device agreement, we need this bland Altman graph. So for the SIMK1, SIMK2, and for the pachymetry, it is in the acceptable range. And remember, when we are doing the excimer laser, what data we need? The K1, the K2, the pachymetry, and then the refractive error. So all these variables are totally showing inter-device agreement. We have got slight problem over here with the Kmax, right? Because over here it's showing 1 diopter difference. So 1 diopter is too much because this Kmax is used in order to check for the progression. Even 0.2 and 0.3 becomes significant now. All the international data so far across all the OR data is lying over here. Have a look at it. This is OR data. 1 diopter difference. The other devices are showing difference of even 2 diopter or even more when you are considering the other Scheimpflug devices like the Galilee, like the Sirius. So OR data is lying exactly with the international parameters. Now this is the third thing, that is the bad D versus the KCP, which is the classification. So for that, we need to make into account this Cohen's kappa, which is the other variable. The importance of this variable is that it will rule out the agreement that has occurred by chance. Now have a look at this. This is known as the confusion matrix. Confusion matrix means the classification that has been provided by the two devices and how closely they resemble each other. Have a look. Scansis showed 28 cases to be normal, and the same has been shown by the pentacam as well. 2 cases were having the keratoconus, and the same were shown by the pentacam and scansis as well. The only problem lies in the borderline cases. Now here again you say, why is there a difference? Remember, whenever there are cases of borderline, all the international data actually suggests that you have to use the multimodular imaging. What does that mean? You cannot stick to one specific thing. That this is a borderline case, you have to go with the multimodular imaging. Like she just mentioned, the use of the corvis. The other important thing is the use of the epithelial imaging. So you have to make into consideration all multiple devices in order to reach a conclusion regarding the borderline cases. Here again, we have got slight disagreement in the borderline cases, but this is again in concordance with the international criteria across all the Scheimpflug devices, right? So in order to conclude it over here, one thing is that we have got agreement for all the practical parameters that are used in Excimer. Only for the Kmax, it is suggested that you should stick to one device. And for the borderline cases, you need to have the multi-modular imaging. I will end up by showing you this one thing. Look, apart from the parameters that are available in the Pentacam, it also has an AI classifier automatically classifying the patient in the normal range, the keratoconic range, or the post-refractive laser vision correction range. So, if I say over here, it has got the features of both the Pentacam and the Sirius as well, because the Sirius tells you, Sirius has got very complicated variables like the SIF, SIB, BCF, BCV. Now, BCV, Biocchi Kalasi Versace Index. You look at into the narration, it will say it is the decomposition of the Zannikis at the temporal apex. Very difficult to identify, very difficult to, but then the users of the Sirius will tell you, okay, fine, these variables are difficult to understand, but we have got an AI classifier. We just look at the data at the bottom and we say that this patient is normal, suspect, or keratoconus. So this ScanSys has actually combined them. It is also giving you the data very similar to the Pentacam, and then it also has an AI classifier as well. Thank you very much.
Thank you, Umar. Thank you. So I think no presenter is left